Now, once again, let me make sure we're clear. 2 definitions. So that picture that I showed you, light microscopy with crescentic proliferation, remember, that's a syndrome, so you could have many causes that may lead into it. Nephritic always is where you're coming from. Tell me about your patient and presentation. Hypertension, hematuria, RBC CAS. We have maybe dysmorphic RBC. We have oliguria. And with nephritic is what I'm coming from. And how quickly will the kidney die? 12 weeks. Now, if you missed this question, I will come out and find you and slap you silly. 12 weeks is rapid. This is not acute renal failure. Completely different definition. And then we'll go into chronic later on. Patients presented with nephritic, everything we just said. H&E, light microscopy will show your Bowman space, which has completely been occupied by crescentic cells, which does what? Restricts and compresses the glomerular tuft. Prognosis poor, and go into end-stage renal failure really quick. Now, with rpgn, there are different types that we'll talk about. Now, it is not important for you to know type 1, type 2, type 3. That's not what's important. However, what I'd recommend and what we have in medicine is that type 1 rpgn include these diseases. Type 2 will include more, and type 3 will be even more. What I would also do is, because it's impossible, in my opinion, to memorize everything at one time. So what you want to do is take a look at type 1 and give yourself an organization pattern. Isn't that much more effective? So type 1, rpgn. Perhaps it's anti-glomerular basement membrane disease, what the patient had. Who's your patient? Young patient, 20s maybe, male more likely, and was coughing. When coughing, found what? Blood, hemoptysis. Also, had hematuria. Why? It's nephritic. Okay. Any sinusitis? No. Why did I put that in the mix? Sinusitis to you should give you a different diagnosis, or have you think about another differential known as, well, once again, you know it as being Wegener, but now what is it called? Granulomatosis with cholangitis. I'll abbreviate it as being GPA. Just to make our lives easy, I'm going to keep repeating that until it becomes part of your unconscious reflex. Next, what else? Could be idiopathic, could be, well, as we said, 10% of the time, good pressure. Under type 2, the category is, well, these are causing rpgn. With type 2, these are immune complex diseases. Let me walk you through this, and you tell me where these immune complexes are located on your electron microscopy. Ready? Post-streptococcal infectious glomerulonephritis. Where did it come from? 2 places, pharynx or skin. Give yourself an approximation of 2 to 4 weeks. Later, your child maybe perhaps presented with hematuria. Do you remember some of the streptosome tests? And some of them included anti-DNase B. The one with the skin, which is 60% of the time they'll present with PSGN, will come from the skin. And at least give yourself S as in skin, S as in streptokinase, being frequently found as being a streptosome test. Next, tell me about the immune complex. Where is it? Use the P to your advantage. Subepithelial. Good. Pattern on immunofluorescence, granular. Another one with deposit. SLE. What kind of stain or marker would you find with kidney damage? How many kidneys? 2. And T, double-stranded DNA. Good. What is a prototype that you'd find here with SLE? It's called DPGN, diffuse proliferative glomerulonephritis. How are you going to use that D for immune complex? D as in subendothelial. Clear. Once again, what kind of pattern? On immunofluorescence. Granular. Excellent. Let's move on to Henoch-Schönlein purpura. What's a better name for this? IgA nephropathy? No. IgA nephropathy or glomerulopathy is Berger. IgA vasculopathy is Henoch-Schönlein. How can you make that differentiation? What does purpura mean to you? Damaged blood vessel, fibrinoid necrosis, bleeding, purpura, IgA vasculopathy. Are all of these dealing with immune complexes? Sure they are. You tell me how HSP, Henoch-Schönlein, is then affecting the kidney. Could you get IgA deposition in the mesangium with HSP? Of course you can. Could all of these result in rpgn? That's the point, isn't it? Let me go into type 3. Type 3, that may result in rpgn. These would be posse immune. What's posse mean? Posse means little. Okay? Posse means little. So you have little immune involvement, but you are ANCA positive. And when the time is right, we'll talk about anti-neutrophil cytoplasmic antibodies being positive. Now, the one that you must know both of these, but the one that you all know so well is granulomatosis with cholangitis. It was formerly known as? Good. Wagner. What else do you want to know as far as current day practice? Is that you know this being C ANCA positive, don't you? What's the third letter of the alphabet? A, B, C. Oh, wow, that's letter C. There it is. So therefore, anti-proteinase 3 ANCA positive. That's a lot of words that you need to know. And yes, you do need to know. Then we have polyhydramnios nodosa. What is this? Well, polyhydramnios nodosa is a medium to small vessel disease. Usually be affecting the abdomen, pain, and could also affect the kidneys. Is that clear? Could it be ANCA positive? Could it be? Yes. 50% of the time, a patient with polyhydramnios nodosa will be P-ANCA positive. What's another name for P? Myeloperoxidase. MPO. Now, if you've never heard of these before, I highly recommend that you know current day practice and the new, not so much new, but the technical names for these C and P ANCAs. Know their associations of the two here, C and P ANCA, or PR3 and MPO. Which one of these has more differentials? You're telling me P ANCA, really? Polyhydramnios nodosa, 50% of the time. Microscopic cholangitis, P ANCA positive. Churg-Strauss, also called allergic type of granulomatosis, isn't it?